So, hello everyone, and welcome back to another Rafael Medina VMR. So today our focus will be on hepatology, and for this session we have two phenomenal educators from University of Michigan who have joined the discussion today. We have Dr. Elliot Tapper and Dr. Sarah Uttal from University of Michigan, and I will ask both of you to introduce each other, and also if you'd like to share a story of how you work together or of an experience that you both had together before we jump into the case. And also, again, thank you so much for being here.
Well, it's a privilege to be here. Thank you very much for the invitation to join you. So I'm Elliot, and I'm at the University of Michigan, where I'm a hepatologist, and I have the privilege of working with Sarah, who is an expert hepatologist in her own right with a specific interest in frailty and malnutrition. And you may not know this, but she's also an expert endoscopist. It is a privilege to work with her in the endoscopy suite. And one of the best parts about it is her Spotify playlist, which I have subsequently stolen and used as the background for all of my grant writing and paper writing. So I learned a great deal from her on all things, from hepatology to pop music.
The pleasure is mine. Thank you so much for this invitation. I was also thinking about the one of a funny memory or something, and I'll say it was truly an honor to be asked to share my playlist. So I'm glad that you're putting it to great use. Thank you for that.
Thank you so much. And then I would ask you both whether you could share the first aliquot with us.
Yeah, let's get into it. Okay. So today we're going to be working on a patient who has a presentation for severe pruritus. So that's the consult question. And I'll jump right in noting that some of the details for this case have certainly been changed, and this patient was cared for at multiple institutions throughout this care that I've kind of tried to simplify. So this is a 67-year-old woman coming in for an additional opinion to hepatology clinic on her itching. She has a past medical history of depression, asthma, and had a rough 2020 where she had a ruptured appendix, some resultant complications that I'll get into, and COVID-19 at the end of 2020. She lives out of state, though she lives in Michigan. And like I mentioned, she's seeking another opinion because the itching has become really life-limiting at this point. She's been itching for about 3 years. She's noted some dark spots on her skin that come and go, and has lost about 100 pounds in the same 3-year time frame. She's also noted some yellowing of her eyes since 2020.
So if I could just jump in to interrupt, is that all right?
Please.
So as I'm hearing this story, first of all, she's coming to liver clinic, so immediately I'm biased as to where this itching could be coming from. But at the outset, we're assuming that it somehow involves the liver. And as you're talking about the rough 2020, it immediately brought to mind two of the sort of more common kinds of things that you would associate in the past medical history. So the ruptured appendix says that this is someone who was very sick at some point and then was probably exposed to a great deal of antibiotics. And so anytime someone's coming in with a cholestatic liver injury, I'm immediately thinking about drug-induced liver injury. Like the second I hear about cholestasis, I'm reaching for, tell me about their medication list. I'm grilling them about supplements. And if there was an exposure to antibiotics, which are by far the most common cause of cholestatic liver injury in the United States, then there we have it. And then this COVID turns out to have a little bit of a wrinkle, because it turns out that there's an entity called COVID cholangiopathy, whereby people who were severely ill, particularly those who are on ECMO, but not necessarily quite hypoxic, end up with a significant ischemic injury to the liver that results in predominant biliary injury. But then you threw a wrench in that, saying it's been going on for 3 years. And then you say that there's weight loss. And now that I have this duration of illness and I have the weight loss, I'm starting to think about mechanical obstruction of the bile duct, potentially something that is an indolent tumor that is slowly resulting in closure of the liver's exhaust pipe, the bile duct. But there we go. I'm forming a little bit of a differential. I'll let you go back to the story.
I'm going to come back with a question of my own then. So I think you mentioned the antibiotics exposure. We wouldn't necessarily expect that to still be impacting her now. What about the COVID related bile duct injury? Is that something that can go on to linger?
Yeah, so I'm not aware of a case where that gets better. And there will be people that will proceed with transplant, or because of their significant comorbidities that they accrued in the course of their illness, they will simply not be candidates for that. But it is typically a very bad prognostic sign. There are people who will survive the ICU and result in the debilitating illness that results from having severe biliary ischemia, but I'm not aware of any cases where it does get better.
Okay. So just maybe to delve a little bit more into that rough 2020, she presented initially in the spring in 2020 with abdominal pain, found to have a ruptured appendix at that time, requiring removal, and had a 2-month hospitalization. Dr. Tapper, you're right, she was quite sick. She required IV antibiotics. And like I said at the start, some of our records are missing. So I'm not quite sure what antibiotics she got at that point. But I do know in the fall of 2020, she came back with an abscess in the right lower quadrant with ongoing antibiotics at that point, specifically Augmentin and ciprofloxacin in the fall of 2020. And at that point, like you mentioned, we're in a liver clinic. We kind of know where this is going. Some of her labs were abnormal. Her bilirubin was 2.6 and her alk phos was about 1,000, which was attributed at that time to sepsis related to her hospitalization and then the antibiotic use. Curious, Dr. Tapper, if this is kind of the first thing out of her mouth in clinic, if that changes anything on your differential.
Yeah, so I would say that we have an extreme, but however, classic presentation of cholestatic liver injury. Yes, I'd like to hear about the other, liver enzymes to sort of round out the way that I'm thinking about it, but this is somebody with a touch of elevated bilirubin and a wild alkaline phosphatase, and I'm now going down the thought pathway resulting from that, which we should get into, because I'm sure that you have an approach to this. But still, the first thing that you want to think about in somebody like this is what kind of exposures they've had by way of medications. And I think the key tip that I'd like to leave somebody with here is that you ask somebody questions about their supplements and their medications, and then you ask them again, and then you may ask someone else to ask them questions. Usually a med student is the one that discovers the supplement that's causing the significant cholestatic liver injury. And if they tell you they're taking a medication or a supplement you never heard of before, which happens to me every other week, that's okay. You plug it into livertalks.gov, and this is a compendium of all the case reports of things that cause liver injury. And extremely helpful. I call it Hepatology Google. But because it's been going on for a long time, I'm immediately thinking about obstructive pathology. Sometimes I would go with an ultrasound. In this case, I'm more interested in cross-sectional imaging, and the cross-sectional imaging of interest here is an MRI with an MRCP. And I would go straight to that just because of the severity, one, and the chronicity, two. Of course, there's a broad differential for an elevated alkaline phosphatase, but that's where the money is right now. I don't know. Do you have anything to add for your general schema?
No, I think I'll just highlight kind of what you said about the medications, because I think it's difficult for people to remember and think through what they're taking. And so sometimes I ask people to go through the start of their day, what they drink, what are they drinking, a tea that they then continue to drink throughout, so specifically asking about those things can be helpful and tricky, especially at the beginning.
Love it. You know, and just a slight sidebar, there was a
Yeah.
recent case report of a patient, not unlike this, published in the Journal of Hospital Medicine, and they did all kinds of funky testing, and then the patient went home, and he called the clinic and said, hey, by the way, I've been drinking this alkaline water that I picked up at Costco. Do you think that could be causing my liver injury? And it turns out that he was in the middle of basically what was like an outbreak of severe drug-induced liver injury from a commercially available alkaline water supplement that caused liver failure through Nevada and California about a couple of years ago. So I would have never picked that up, but the way that you were phrasing the way you would elicit the history, it would be very sensitive for those kinds of supplements. So I really like that. I just wanted to call that out, that would be a very successful strategy.
Yeah, and that's a public health hazard, right? So I'm glad that was picked up. Maybe if we could just progress to the next aliquot with the pertinent medications on that note. She is on escitalopram, a vitamin D supplement, and then she was recently started on ursodiol, 300 milligrams twice a day. She is allergic to contrast media. She has no family history of liver disease specifically, and she does not smoke tobacco, use drugs, and drinks about a half glass of wine per week. So I mentioned that the ursodiol was started for her itching. I'm curious your thoughts on that, and if that's your first go-to.
Okay, so let's talk about the management of itching. And I think a lot of people start ursodiol, and then you'll see most hepatologists sling it with ease. We love prescribing it because we know that it's safe, and we hope that it could treat the underlying condition in many cases. But unfortunately, it doesn't improve itching. So there is no evidence that ursodiol will improve itching in the sort of primary biliary diseases, PBC, PSC, drug-induced liver injury. There is one condition where ursodiol does improve itching in the largest randomized trial of intrahepatic cholestasis of pregnancy. It improved itching for mom and did not hurt baby. This was published about 3 years ago in the Lancet. So now, is it a bad idea to use? No, but it's not going to help the patient. So should I tell you what my first line treatment is?
Yeah, let's go for it.
My first line treatment is moisturize yourself when you get out of the shower. And maybe you could take a Benadryl or hydroxyzine before you go to bed. And even for people in whom you have a really high pretest probability that it's biliary disease causing the itching, still the most common cause of itching is going to be dry skin. And then they Google that their elevated alk phos is associated with itching, and it makes it real bad. And you'll be surprised how many people with escalating alkaline phosphatase will thank you for telling them to moisturize. Okay, so assuming that doesn't work, like I said, hydroxyzine or Benadryl in a pinch when they're about to go to bed. The itching is typically on the trunk and the arms. So if you need to differentiate it from dry skin itching, and it gets worse at night. Okay, but so then my first line therapy is cholestyramine. Now, cholestyramine can be dosed in like a scoop or a packet of 4 grams. And you'll see a lot of people, including hepatologists, prescribe this daily. And then they'll call 2 weeks later and say, I'm worse, or I'm no better. And then they'll say, oh, the cholestyramine didn't work. Or should I increase the cholestyramine? So when you are trying to address symptoms, it doesn't make much sense to start out with a low ball dose. So I will start at 4 grams BID, if not more, and then titrate down to the minimum effective dose, rather than spinning my wheels thinking, is this failure of cholestyramine or inadequate dosing? And so I would just go big and then pull back. Now, the side effects of cholestyramine are twofold. One, it will bind medications, so they has to be taken on an empty stomach. And then 2, constipation. But that's really just about it. And for free, it will improve your cholesterol. Sometimes I will play around with cholestipol, which is basically pill form of cholestyramine, and allows you to more accurately titrate the medication because it's 1 gram per pill. But that's my first line therapy. Do you want to get into like second line stuff, or where should we go from here?
Let's hit second line, and then maybe that's
okay. So
another
cholestyramine, that's the go-to. Okay, and then I would, and then I think when you're going to start someone on a symptom-based treatment, I think what you should do is ask them to rate how bad their symptoms are on a scale of 0 to 10. This so-called like visual analog scale is both valid. Okay, this is what we do in trials of drugs to treat itching and other symptoms. And 2, it's scientific, like you put in the chart that they were an 8 out of 10 last week, and then they're calling you saying they're itching and they're a 4 out of 10. I'm not sure I can make much of a difference, or I don't think that the side effects are worth it. But if they tell me they're still a 7 out of 10, I now know that it's a priority for the clinical management. So using a visual analog scale, putting it in the clinic, put in the clinical notes so that you know where you stand. So my next best bet is we have a few options. One is rifampin, which modulates the transduction of itch in the dermis. And a lot of people are scared of using it, so it's not frequently used, but it is effective. The second one is naltrexone. Naltrexone is, it reduces the sensation of itch. And I like to use it because it is a safe medication. And then after that, you'll see randomized trials for things like sertraline, which gets at the sort of catastrophizing that happens when you have itch and you get very anxious. And then it probably also dulls the sensation of itching. And then beyond that, you'll see wild things like UV therapy or nasobiliary drainage that get thrown around in terms of case reports. I may be missing a couple, but as long as you remember naltrexone, rifampin, and sertraline, you've got 3 options of generic medications that you can use to help a patient feel better.
And go big or go home. That's great
Yeah.
learning. I'm going to push you a bit because you said naltrexone is a safe medication. And I know that you're passionate about its use in other liver-related conditions. I'm curious if you could speak on specifically in alcohol-related.
Yeah. So, people can get itching and cholestasis and they can have severe liver disease at the same time. And so the question is naltrexone safe? So naltrexone was trialed in people with cirrhotic biliary disease. But then in this alcohol use disorder literature, there started to be a lot of fixation on an FDA black box warning that it could cause elevated liver enzymes. So the biliary people ignored that or forgot about it, while the alcohol people sort of overemphasized that black box warning. So it caused elevated liver enzymes in a trial where it was being used to treat obesity or interest in food. People saw elevated liver enzymes and got better when they stopped it. It was like 8 or 12 people, if I recall. It's never been observed in a trial for alcohol use disorder. Now, because alcohol also causes elevated liver enzymes, and everything exists in context of trade-offs, and there's no evidence in the alcohol use disorder population, the FDA actually deleted that black box warning, but that didn't stop people from repeating that there was a black box warning. So it's been deleted since then. At EASL, which is the European Association for the Study of Liver Disease, an abstract was presented of the first randomized trial of naltrexone for people with known cirrhosis, and they didn't see any safety signals. And before that, there have been a number of retrospective cohort studies, one from the national VA cohort led by Dr. Anahita Rabi from Yale, and another from University of Southern California, and where they saw no safety signals and improvement in overall mortality for people taking naltrexone. So long story short, I don't have a problem using that medication in people who can benefit from it.
Thank you for going on that important detour with us. You're right. A lot of those patients are itchy too. So
yeah,
we got to treat them. Yeah. Okay, let's move on to the physical exam. She in clinic, now this is, again, she's presenting to our hepatology clinic for another opinion. She's afebrile, 36.0 Celsius. Her blood pressure was 115/56, heart rate 65, satting 98% on room air. In terms of physical exam, she appeared in no acute distress. Her conjunctiva appeared icteric, and I guess that's a learning point. It's the conjunctiva where the bilirubin deposits, not the sclera. Her neck was supple, no lymphadenopathy, chest cleared auscultation with good air movement, regular rate and rhythm on cardiac exam, did have a 1 out of 6 systolic ejection murmur. Abdomen was soft, non-tender, non-distended, no masses or organomegaly were palpated, no ascites, no edema on the extremities, and her skin was notable for excoriations across her trunk, back, legs, and arms, also notable for jaundice. On the neuro exam, she was alert and oriented with normal speech and no asterixis. Any other signs that you'd be looking for on physical exam for this patient, Dr. Tapper?
Not really. I mean, I think you see the excoriations on the skin. This sort of orients you to the clinical priorities of the patient, right? Like, I want her to feel better and that there's urgency to resolve the symptoms. I'll look for signs of chronicity. You can sometimes see in people with chronic cholestasis, the xanthelasma. I'll look for signs of chronic liver disease. You mentioned asterixis, obviously, but I'll look for muscle wasting, malnutrition, and spider angiomas. But basically, if I was seeing this person in clinic, I would just be anxious because I would like to just get her in an MRI.
Okay, well, it's going to be a bit before we get that, but we can at least get updated labs. Her bilirubin is now up to 5.8. Her direct is 4.5. AST is 239, ALT 235. Her ALK phos is 1,329. Protein 8.4, albumin 3.8. Her white blood cell count was 6.5 with a hemoglobin of 11.5 and an MCV in the 90s, 93. Platelets at 277. Sodium was 136, potassium 3.9. Chloride was 102, CO2 28, BUN 23, creatinine 0.75, glucose 95, and her INR was 1.0. So we know that her ALK phos has gotten worse. It actually peaked at 1,700 a few months prior to this evaluation, and her bilirubin is now higher as well. What additional labs here? We know that we want to be cost effective in our liver workup, and this is where the money's at. I know you said you wanted an MRI, but let's go through what additional labs might help us at this point.
So at this point, we know that there is something, the game is afoot, right? This ALK phos is climbing. She's got a big old ALT as well. She's getting progressively jaundiced. So something is not right. And I'm not aware of PBC behaving like this. PBC with some autoimmune features, then possibly. I'm not aware of a lab that is going to help me here. So if you think that PBC is possible, right? It would have to be there plus something else. And we need to get to that other thing and then resolve that before focusing on the PBC. If you think that autoimmune is what's driving at least part of this, then you could get the labs, but they wouldn't change anything. They wouldn't change the need for imaging. And if they were negative, and that's really where my head was at, I would be going straight to liver biopsy as the principal mechanism for diagnosing autoimmune hepatitis. So this is a person who I I'm just not, I'm not aware of a lab that would be helpful in this case.
I'll tell you that during her initial evaluation, the concern was for PBC, other than obviously the DILI initially. I think seeing a middle-aged woman with the alk phos and the bilirubin, they did end up getting a large number of our typical liver labs. So I'll go through them. The hepatitis acute panel was sent, that was negative. So Hep A, IgM negative, Hep B surface antigen, and core antibody negative, Hep C antibody negative. They did get an iron saturation. It was 36% with a ferritin of 178. In terms of the autoimmune, her ANA was strongly positive. Her anti-smooth muscle antibody was also positive at 1 to 20. And her antimitochondrial antibody was also positive, although weakly so. It was then repeated and then more strongly positive. Her cholesterol was quite elevated. Total cholesterol, 354 with an LDL of 275. Triglycerides were 102. A ceruloplasmin was checked. It was high, 54. Her TSH was normal, 0.78. Her vitamin D was low at 9. Her alpha fetoprotein was undetectable, and her alpha-1 antitrypsin was a normal phenotype. So I'm curious if I understand the workup for PBC, right? And now we're stuck. We've sent these labs and now we're stuck with interpreting them, right? Does this change any of your thinking? I know you said PBC doesn't usually look like this. I'm curious what you think now, knowing these labs, if anything changes.
Yeah. So just to be clear, right? Like PBC can present with these numbers, but what we're talking about is rapid deterioration in front of you, right? So that's why I would downplay the role of PBC as the first mover here. Now, if you told me that you got an antimitochondrial antibody, which is positive in 90% of cases of people with PBC, then I would not fault you for that. But as you know, I have a medical comorbidity whereby the ordering of a ceruloplasmin within a 5-mile radius results in a mild splenic infarct, and I can't. It's very hard because at this point I'm functionally asplenic because of all the ceruloplasmins that you've sent, and this one hurts my feelings because the woman is 67 years old, and diagnosing Wilson disease in someone over the age of 40 is nearly case reportable. There are about 80 cases in the literature. I'm sure there are many more in real life, but we're talking about something that's rare, and it certainly wouldn't present with cholestatic liver injury. Now, neonatal jaundice can be explained by alpha-1 antitrypsin, but it's been a long time since she was a neonate, and alpha-1 antitrypsin should never be tested for with a level. So I am happy that you got the phenotype in this case, and we can congratulate her on a normal phenotype, but it would have never explained any of her liver enzymes. And of course, a ferritin, you're trying to get at hemochromatosis. And if hemochromatosis did this, then it has mutated into a new condition, hitherto unknown to man. So I would say of the tests that do not cause an acute abdomen, for me, it would be the ANA, the anti-smooth muscle, and the antimitochondrial antibody. And everything after that is balderdash. Now, the elevated cholesterol is interesting because it speaks to the chronicity of the biliary disease. And people with chronic biliary injury can get wild cholesterols, wild. It's not like I'm checking it to look at it, but in the retrospectively, I can explain it that way.
Would you mind just explaining that and maybe going into why the vitamin D might also be helpful and that it's low?
I'm not sure why the vitamin D is low in people with with cholestatic liver injury, except to say that this is a person where we have abnormal processing of the bile flow, and so these are fat-soluble vitamins, which simply might not be making it through the liver. And then why the cholesterol is high, it's the idea here is that cholesterol is part of the is excreted in the bile, and takes part in the enterohepatic circulation. So you have receptors in the ileum that sort of pick up the cholesterol that you need, and you waste the cholesterol that you don't, unless you have other states that result in increased cholesterol production or absorption. And in this case, she's just not effectively flushing the cholesterol. Now, it could be that the vitamin D is low because she is not in the sun, or because she's otherwise malnourished, or because there's other comorbidities that could influence the total level. But to the extent that she has functional biliary obstruction here, you're going to see abnormal fat-soluble vitamins and cholesterol. A comment was raised about PSC, and PSC is actually a good thought. It's also rare, okay? And PSC has the ability to sort of jump stages very quickly, whereas PBC does not. And that's because PBC is a small duct disease, and PSC is more often than not a large duct disease. And so, the model of cirrhosis that we study in rats is called the bile duct ligation rat. So you tie off the bile duct, and the rat will develop cirrhosis and jaundice within days. And so if you have an obstruction of the large duct because of PSC, you can go from being non-cirrhotic to cirrhotic very quickly. So PSC is possible, although epidemiologically less common. So it's definitely on the list, but I don't have a blood test for that. So that's why I need to know that MRCP.
I think we have a question.
Amazing. I was having a question about this very high alk-Phos. I know depending on the elevation of the alk-Phos, we always likely like to differentiate in what kind of direction it goes. Do you have any approach on that, Dr. Elliot? You
mean like whether it's coming from the liver or not?
Exactly, yeah. This one, and also the amount of alk-Phos that is being elevated, like if it's only mildly elevated and if it's very, very high elevated.
Okay, yeah. So this is a case where you have an elevated bilirubin, elevated ALT, and itching, and so like I'm really it's like a slam dunk that this is coming from the liver. Okay, more often than not, we're meeting people with an alk-Phos like 190 to something. And like they have mildly elevated liver enzymes because they have metabolic liver disease or something. And so you're starting to think like, could this be from the liver? And so commonly you'll see people say, check a GGT because that's specific for the biliary epithelium, but it's not. It turns out that the GGT is elevated in all liver diseases, particularly alcohol, right? But also NASH. So GGT is not helpful, even if you see that in a textbook or review article. So when I need to know if it's coming from the liver, I will send it out and get it fractionated, and it will tell me if it's coming from the liver or not. That's my go-to. But I'm not doing that for every elevated alkaline phosphatase, like this lady who comes to me with a story that is too solid to question.
Amazing, thank you.
I will say that she did get the fractionated alk-Phos as the next lab, as well as some immunoglobulins, which I think will lead us into something in the chat. So the liver 1% on the alk-Phos was 69 within the normal range. Liver 2 was 21, which is high. Our upper level of normal is 8. And then her bone percentage was low at 8.6. with intestine being within the normal range. Would you mind just going through kind of the liver 1, liver 2, and how that helps you at all, or does it?
Yeah, it does not. Yeah, so it's not going to be particularly instructive for the specific pathology to me. I don't know. Have you had a different experience?
No, just the fact that it's high.
Yeah,
Yeah.
that's what
I think
and
a
it
lot
is
of people,
helpful.
yeah.
Yeah.
And I think a lot of people wonder about 1 versus 2 and if it could be from something in specifically. And then the immunoglobulins were sent too. And I think we have a question in the chat. Could autoimmune hepatitis be possible given the chronicity, cholestatic pattern, and elevated protein gap? And I'll say all of the immunoglobulins were high. The IgG was in the 1700s. IgA and IgM were also high, and IgG subclasses were also sent with 2 and 3 being high and 4 being within normal limits. Does that help you at all with that question in the chat? And could you speak to if this could be autoimmune hepatitis?
So, so autoimmune hepatitis typically has an elevated IgG, and there's a sort of non-invasive scoring rubric for the possibility of autoimmune hepatitis. And the higher you go with your IgG, the more likely you have autoimmune. And you get some points, like if it's greater than 1500 and so forth. So although it's elevated, I think you had total IgG at 1700, it's sort of like middle of the road. The problem is that people with cirrhosis have elevated IgG. So it sort of helps you understand autoimmune hepatitis, like the possibility of it, but it's not specific enough. And so that's why these tests, they're sort of helpful in prioritizing whether you would do a biopsy or not. But autoimmune hepatitis is really the last diagnosis that's made almost exclusively by biopsy or empiric trial of therapy.
Okay. I think at this point, she was sent home with the plan for cross-sectional imaging. So we're finally going to get slightly closer to where you want to be. So a CT abdomen pelvis was done. Her liver was slightly enlarged, so slight hepatomegaly was noted. No obvious large liver mass was seen. And her spleen was normal in size with a few small calcifications consistent with granulomas. She actually did get a liver biopsy with that question of autoimmune. And it was noted that the biopsy was adequate in size for interpretation, and she had moderate diffuse bile duct proliferation with mild mixed portal inflammation and mild portal edema. They did a trichome stain, though they did note that it was difficult with the significant bile duct proliferation, and there was a potential bit of portal fibrosis, but there was no evidence for cirrhosis.
So are you like trying to tease me by saying?
No, I'm just going to get to it.
Okay. I'll just say
it took her years.
Yeah. So CT is just not the right test for the liver, right? It is a great test to look for masses in the liver, right? But it's not a great test for looking at the bile duct. You do need an MRI, and that sucks, I know, but it is. And then this biopsy, the biopsy is basically laughing at us. Okay, that's what that says. Moderate diffuse bile duct proliferation is basically, if you translated that to English, elevated alkaline phosphatase with a high bilirubin. That's what that means. I'm really glad there's no cirrhosis. It makes me feel like if we could diagnose this and fix it, we can resolve this whole thing. But unfortunately, this biopsy was useless. Okay.
So I'll get to it in a second, but I will say that I think there's learning here because this took her 3 years. And I think part of it was that she was struggling with this itching. She went to, I think, 4 different institutions, all of whom were starting over. And so I'm curious, obviously she was, searching for help. But I'm kind of curious, what's your approach as maybe the 5th, 7th hepatology opinion, or as someone who's seeing patients who are also, of course, being seen by their primary care physicians who are trying to coordinate their care and advocate for the patient? What is your approach to communication with those other specialties and with the primary care doctor to try to progress this person's care?
Oh, yeah. So I definitely think, so you're seeing someone in the consultative situation, you're probably going to repeat some of the things that have already been done before. I would definitely not repeat this ceruloplasmin, but if there was cross-sectional imaging, I would do it no matter what, because liver radiology is like Olympic level hard. And even the best ones will like look at it again and see, oh, I missed that. So getting a new scan is like, that's obligatory. I will say in my own experience, I've met people with milder disease that sort of, but intermittent cholestatic disease, I'll get an MRI and it looks fine. And then eventually I'll go straight to the biopsy. And then I once got a phone call at the time of the biopsy. They're like, she's got bile duct dilation, brand new. And the whole time it was just a stone going up and down in the bile duct causing intermittent cholestasis. So we all get fooled. I mean, so people get delayed diagnosis all the time. So I am not trying to besmirch anyone's good name. I'm just making jokes about this MRCP. But in this case, I try to call the PCPs. Some PCPs want to hear from me. Others don't. I think most people just want somebody to take over and quarterback the further management of this.
Okay. Well, to get there, she did get an MRCP. And it does give us a bit of a new twist on this. So the MRCP read, it says normal appearance of the intrahepatic ducts with prominent right hepatic artery indenting the common hepatic duct. It also noted a heterogeneous hepatic enhancement in the arterial phase, which normalized on subsequent phases, thought to be of unclear significance, and multiple but stable enlarged lymph nodes in the area. So you had jumped right to concern for obstruction, and this was a different flare. Exactly, right, Andrew? I haven't heard of this either. So curious if you've seen this before.
No. So, so you worried about obstruction, mechanical obstruction. I was worried more distally, things like duodenal adenoma, pancreas, like neuroendocrine cancer of the pancreas. A stone can do this. People can present with chronic stone obstruction. That's where my head is at. Then, if you're going to talk about blood vessels compressing the bile duct, the most common one is portal vein thrombosis. So you hear about cavernous transformation. What that means is varices are forming off of the portal vein to offload the obstruction caused by chronic thrombosis, and those varices can choke off the bile duct. And as Dr. Sanchez mentions, you've discussed portal biliopathy. So that is not common, but is certainly more common than the hepatic artery taking down the bile duct, which this will be the first and I hope the last time that I've heard of this.
Yeah, so wild. And that's where she's at right now. And so the next step is she is getting a repeat MRCP to see the current status of her biliary obstruction. But they're debating an ERCP for potential stenting of the biliary tree to try to prevent that compression. Any other thoughts on additional steps for her?
Yeah. So what I would say is, I think the easiest thing to do is to try to reinforce the bile duct with a stent. And now a stent may not solve this permanently, but I mean, realistically, the definitive solution here might be bile duct reconstruction surgically. And before someone goes to that, then you would want to have basically a time-limited trial of biliary reinforcement here. So I think the idea of sticking a stent in there and hoping that it'll be able to fight back against the hepatic artery is completely reasonable. There is no way to revise the hepatic artery safely. So in this case, I think that's the right strategy.
Amazing. I also had some remaining questions during the VMR. When you mentioned about antibiotics also being some cause for a drug-induced liver injury, I would like to ask you about the typical timeline we have to consider antibiotics being a cause for something like a DILI.
Yeah, so people can have variable presentations, and so the most common cause is going to be augmentin, amoxicillin clavulanate. Although any antibiotic can do this, it just happens to be that is a very common one, and courses are short, right? Typically, and then you will see the presentation within a couple of weeks after starting it, or if you pick it up later, it could be more advanced. And then there's a classic drug-induced liver injury from minocycline, which is technically an autoimmune hepatitis, and that usually happens years into the course of people taking it for acne treatment. But usually these idiosyncratic drug-induced liver injuries, they typically happen within days to weeks after starting it. So it's not going to be like you stop the amoxicillin and then a year later you end up with a liver injury.
Incredible. And what I also want to ask you is there any way when labs can help us whether something is more like intra versus extrahepatic cholestasis?
So I think I'll make two comments. The first is that I think there's an overemphasis of the term like cholestatic or hepatocellular liver injury, and you'll see these sort of R indices. Everything exists as a spectrum, and so if I see something that's predominantly cholestatic, it might lead me towards thinking about obstructive physiology, but it's not going to seal the deal for a specific drug or not. So that's one. And then two, intrahepatic versus extrahepatic. So you're going to see there's always going to be proximal, bile duct that's proximal to the level of the obstruction. So you're always going to see an elevated direct bilirubin. I'm not really aware of it in clinical practice of a specific ratio or level that is going to help me pinpoint this. In this case, I knew that the obstruction was going to be more distal than PBC, just given the amount of liver injury that was happening. So a giant chunk of the liver is being affected by this. So that would be the only degree of localization, right? So the more liver that is affected, the higher the ALT and the AST. Okay, that's one way of thinking about it.
Wow, so much learning. And what I also wanted to ask is, since we were talking so much about cholestasis and obstruction, if there's any way something like an approach you have for obstructive disease management.
So the first thing to do is to make sure that there is you've gotten the right kind of cross-sectional imaging, and then you're asking like, well, what would be the next like intervention? And so here it's like, is it accessible endoscopically? Sometimes there is an obstruction that is just too high up for the endoscopy, or they have altered anatomy. For example, it's happening in somebody with a Roux-en-Y gastric bypass, in which case I would be referring the patient for a percutaneous transhepatic cholangiogram to do the same thing that the ERCP would do, but through the liver. Does that answer your question?
Yes, it totally does. Thank you. And there was also another question coming up regarding the positive ANA antimitochondrial antibodies and the anti-smooth muscle antibodies. As you said, that autoimmune hepatitis and PBC in this case is less likely, but Would you like to comment on this question, what we would make with these labs right now here?
Yeah. So like I would be comfortable not ordering these, but then you order them and you start to tell yourself stories about what could happen. But in fact, she just wouldn't have benefited from ever knowing. So ANA can be positive in a huge chunk of the population for other reasons. And for people that have a positive ANA and a non-autoimmune hepatitis, they don't have worse liver disease. So just because you have an ANA doesn't mean your liver is going to be sicker. And so that's well known. An anti-smooth muscle of 1 to 20 is so low that, remember I was telling you about that non-invasive scoring system for autoimmune hepatitis? 1 to 20 gets you 0 points on that scale. So a lot of people have that. Most people that have it, there's nothing. If you had to associate one disease with it, it would probably be asthma or reactive airway disease that you would see. Antimitochondrial antibody is interesting because it's going to be positive less frequently than ANA, by far less frequently than anti-smooth muscle. But in this case, we think we can't really exclude PBC because she's got this biliary disease, but we don't have any histologic evidence for it. But let's just assume that the biopsy it just completely excluded it. We were able to resolve her condition and we can move on. But she's stuck with this AMA positivity. Okay, so the cumulative incidence of PBC in people who randomly got an AMA because somebody ordered it for strange reasons is about 15% at 10 to 20 years, depending on the population-based cohort that you look at. So this tells you that some of the people with a positive AMA will go on to develop PBC, but the vast majority will not.
Wow, I've learned so much. And what I want to ask is, Sarah, do you have any teaching points that you would like to highlight about this case?
Yes, thank you so much. So I think we started off with the management of cholestatic related itching or pruritus. And I think this was so classic to see someone start on urso, again, not meaning any harm, but potentially not benefiting either. So I really appreciated Dr. Tapper's approach and going through all of those medications. So write that down, it'll come up for sure. Thinking through going back to her history and how to take a well-rounded history in terms of exposures, specifically medications, asking 3 times, asking in different ways, trying to help someone remember. And then I just want to highlight again, I know I benefited by looking through, and you guys didn't see everything, but gosh, this patient was seeking help, was seeking care. And I do think a little bit was lost in communication. And so sometimes picking up the phone and chatting with the PCP or chatting with other consultants if necessary is a huge learning point that I would emphasize. Any other major learning points to emphasize, Dr. Tapper?
So I really think that you hit it there. One, I really like the way that you elicited the drug and supplement history, and I will be doing that for the next time I meet a patient like this. Number 2, I really think I want people to be comfortable with precision medicine, which is letting the history and presentation guide the kinds of tests that you're ordering. There's no medical legal liability for not ordering a test if it wasn't indicated. And because we have a longitudinal relationship with this patient, we can see what happens. So there's no expediency in doing all of this extra stuff. Cross-sectional imaging is the bedrock of cholestatic liver injury evaluation, and the test that is required is an MRCP. Beyond that, I don't have much else to add to that.
I think we need to remember our go big or go home too. That was a good catch. I'm going to remember that.
Oh yeah. So anytime you're treating a symptom, right? Like don't slow play. This lady's scratching herself and is being tortured by her liver disease, right? So throw the book at her with the cholestyramine And then if she comes back saying, my itching is much better, but I haven't pooped in 3 days, then you know you've overdone it, and you peel back and you try to find that minimum effective dose. But there's no point spinning your wheels. Our goal is to help her feel better.
And if I can provide one last piece of advice to those on the call or those listening, go to Liver Clinic. This is a place where you can learn so much, but also might open your eyes to an excellent career. So think about it. It's not just what you see in the hospital.
Thank you so much both for coming, Dr. Sarah and Dr. Tapper. I think we have all learned so much through this case. And before ending the session, and also just wanted to highlight for the listeners, here, Dr. Tapper, who is the director of the Michigan Cirrhosis Program, he is also the editor-in-chief of the Hepatology Communications Journal, and his primary goal is to empower patients to enjoy a high quality of life. And I just wanted to mention that, and as you can see through this whole incredible discussion, what an amazing educator he is. And also thank you so much, Dr. Sarah, for all this amazing teaching. Just wanted to ask, do you both have any remaining words before we end the session?
It was a privilege to join you tonight.
Yeah, thank you so much.
Thank you. Then see you all again next time, hopefully. Bye.